Jaundice, bilirubin, phototherapy lights, these are things that you will encounter every single day in your work as a NICU nurse, and it helps if you are able to understand the why behind what we do. I'm Liliana, I've been a NICU nurse for 3 years, and I want to be able to teach you NICU topics in a way that is super easy to understand, in a way that isn't a lecture style, just a casual conversation. Today I'm going to explain what the different types of bilirubin are, why we check for them and how, what jaundice actually is, and how we treat it in the NICU. We are even going to touch briefly on pathologic jaundice and cholestasis, so definitely stay tuned for that. I have timestamps of all the different topics in the video, so if you want to just jump to a specific topic, you can. To start out, most of us remember from nursing school that jaundice is an accumulation of bilirubin in the blood. Now, it's really important to understand and remember that yellowing of the skin in itself isn't jaundice. Yellowing of the skin is a symptom of jaundice because bilirubin, that substance that builds up in the blood, is yellow in pigment. So that's why the skin will kind of take on that yellowish color. To understand jaundice, we first need to understand that there are different types of bilirubin. There is indirect or unconjugated bilirubin and direct or conjugated bilirubin. These two values added up together makes a total bilirubin value. Unconjugated or indirect bilirubin gets its name because it cannot transport on its own. It's not water soluble, it is fat soluble and needs a protein like albumin to be able to transport to the liver. Direct bilirubin, on the other hand, is water soluble and can transport on its own. Unfortunately, there's no way for us to test for indirect bilirubin on its own. You can only send a lab value for direct bilirubin and total bilirubin. To find the indirect bilirubin, you would have to take the total bilirubin, subtract the direct bilirubin, and find your indirect. To check these lab values in the NICU, we usually send a blood test off to the lab. In NICU, you can prick a baby's heel for blood, or you can do a venous stick. There is also a way to check for total bilirubin without having to send a value off to a lab. It's called a transcutaneous bilirubin. A transcutaneous bilirubin uses this little device that you put on baby's forehead or a baby's sternum. It doesn't hurt them at all, and it measures the amount of total bilirubin. Not every NICU has this though, so yours may or may not. The most accurate way is always going to be a blood test. But it can be nice if bilirubin levels have been fairly low and they just want to do a check without having to poke the baby for blood. When we typically think of jaundice in newborn babies, we are thinking of physiologic jaundice. This results from the breakdown of red blood cells that produces indirect or unconjugated bilirubin. When a baby's born, their liver is still a little bit immature, so it is not prepared to handle all of this unconjugated bilirubin that is being transported to it, so some of it can build up in the bloodstream, leading to jaundice. In newborns, this usually peaks after 24 hours of life, and by 1 to 2 weeks of life, the baby's liver is able to process all of the indirect bilirubin that's being transported to it. Sometimes the bilirubin stays low enough that we don't have to intervene. However, the reason why we check for it is because really high levels of bilirubin in the blood, even this indirect bilirubin, can lead to something called kernicterus, which is when bilirubin starts to build up in the brain and can lead to neonatal seizures and long-term neurologic complications for the baby. We obviously don't want the jaundice progressing to this point, so we will intervene with things like phototherapy, IVIG, or in extreme cases, an exchange transfusion when we are worried about the bilirubin levels rising. The easiest and most common way we treat NICU babies for jaundice is through phototherapy. Phototherapy is typically a blue light, either in the form of a blanket that we wrap the baby in or in the form of overhead lights. It looks kind of like a tanning bed. What's cool about phototherapy is this light actually gets into the bilirubin molecule, makes it change shape into a form that is water soluble and can be easily excreted by the body. Bilirubin is usually excreted through stool, so the more the baby stools, the more bilirubin is getting out of the blood, hence the jaundice being treated. Providers will usually order phototherapy to be in place for 12 to 24 hours at a time until we check the next level of bilirubin. Super important tip for NICU nurses that you turn off any phototherapy lights or blankets while you're in the process of drawing a bilirubin lab. If you leave the phototherapy lights on while you're collecting the lab, it can interfere with the results. I've seen babies need phototherapy for as little as 12 hours to as long as 4 or 5 days. Sometimes babies will also go on phototherapy, come off once their levels come down, and then all of a sudden we check the next day and they've kind of rebounded back up and they'll have to go back on. So I usually just explain to parents that it is very normal for this to happen. That kind of covers all things physiologic jaundice and indirect bilirubin. On the other hand, pathologic jaundice is caused by a high direct bilirubin. Direct bilirubin can start to rise when there is an interruption in the flow of bile from the liver into the intestines where it helps break down fat. Normally, full-term babies or even premature babies shouldn't have a problem with this flow of bile, so we usually don't have to worry about this high direct bilirubin unless they have something genetic that we are watching their liver for. However, some NICU babies rely really heavily on TPN and lipids for their nutrition for a long period of time. Babies with short gut syndrome, a high ostomy, or any kind of long-term feeding intolerance can be on long-term TPN and lipids, and that will eventually lead to an interruption in the flow of bile, leading to that bilirubin rising. Once that direct bilirubin rises to more than 20% of their total bilirubin, that gives them the diagnosis of cholestasis. If a provider is worried about a baby possibly developing cholestasis, they will be routinely checking their total bilirubin levels and their direct bilirubin levels through a blood test to make sure that the direct bilirubin is staying below 20%. If the direct bilirubin has risen to over 20% and your baby does have a diagnosis of cholestasis, they may be started on a medication like Urosodol or Actigol. They may have TPN and lipid cycling, where we have to turn the TPN and lipids off for a short portion of the day, or they may be switched to a more gentle form of lipids. It's really great that we are able to keep short gut babies and babies with really bad feeding intolerance going nutritionally with TPN and lipids, but that adverse effect is cholestasis. So we really need to make sure that we as NICU nurses are advocating for our providers to be checking in on their total and direct bilirubin levels to make sure we are catching things early, because if it is not caught early, it can progress to biliary atresia, which is a total blockage, meaning that baby needs surgery. I hope this video helped you understand jaundice, cholestasis, bilirubin a little bit better as a bedside NICU nurse. Thank you guys for bearing with me. This is my very first YouTube video and it was really fun to film. I am planning on posting more NICU educational topics as well as all things kind of NICU nursing lifestyle and being a nurse in your 20s. So definitely subscribe if it was helpful and let me know if you have any questions in the comments. I'll see you guys next time.